Hey everyone, welcome back to all my listeners. Now I hope you're all having a great day so far. I know I am. And if it's your first time finding me, thanks so much and welcome. Welcome to my 8th episode of Season 6. Today is Wednesday, June 22nd, 2022. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. Now, I just wanted to start the show off by giving a big shout out to my good friend, Jennifer McNamara, on her podcast, Life as a Coder podcast. Now, you know she's been a guest on my podcast a couple of times in the years past. Now, we know she's simply fabulous and fun, and she's always filled with a wealth of information. And she graciously invited me onto her episode today discussing the Big Bad Boy Modifier 25. So please head on over to her podcast and tune in as well, because we both really did provide some valuable insights and facts on this notorious modifier. Now, in my episode here today, I'm going to be diving into my compliance tip, and that's going to be on the in-person mental health visit requirements in the RHC and FQHC settings. And I'm going to be rolling out that red carpet once again and showing off my special newsworthy guest today, Glenn Krauss. And I close out today's episode with some inspirational words on vision and leadership from the Japanese philosopher Daisaku Ikeda. If you checked me out on LinkedIn, you know I'm all about compliance and protecting our physicians and our valued healthcare professionals when it comes to the business of medicine. I hope this week with me brings you enough to take back to your organizations, to want to dive in deeper, to use my tips and best practices to ensure success. I hope this podcast will help you boost the quality of documentation capture and improve coding accuracy as you help all your providers paint the medical picture. If you like what you're hearing, please go ahead and hit that subscribe button now so you don't miss another episode. Please write in a review and kindly drop me a 5-star rating on Apple Podcasts or wherever you listen to my podcast. I'd really love your support. And as always, a friendly disclaimer. Remember, I'm bringing you the news, current healthcare industry news, my compliance tips and my recommendations based on my over 10 years of experience in front office, in back end, in coding, and in billing for multi-specialty physicians, in compliance, and in auditing for both E&M and surgical operative reports. These are my opinions alone and are not to be construed as legal advice. So let's get into a very special newsworthy that features my guest today, Glenn Krauss. I'm so excited for today's session with you, Glenn. I finally could bring you on. I found the perfect time and perfect episode to bring you here. Okay. So why don't I tell my audience about your impressive details in your career?
Great.
Let me read them a little bit of your bio.
Okay. Yeah.
Now, Glenn is a well-recognized and respected subject matter expert in the revenue cycle. Throughout his career, Glenn has placed emphasis and keen focus upon collaborating and working closely with physicians in promoting, advocating for, and education on achieving sustainable improvement in the clinical documentation space that reflects communication of fully informed, coordinated patient care. Right. Now, he possesses 25 plus years of progressive, practical, hands-on experience in clinical coding and documentation improvement. Glenn is an avid believer in the philosophy that the quality of the medical record documentation strongly correlates with overall quality of care and, of course, the overall achievement of a high-performing revenue cycle. Now, what sets Glenn apart in the clinical documentation improvement arena is his recognition of clinical documentation effectiveness, accuracy, completeness, and contextual consistency is fundamentally integral with all components of the revenue cycle. And of course, throughout his illustrious career, Glenn has served in various environments, from the very large hospital systems to academic medical centers, community-based hospitals, and critical access hospitals. And my favorite highlights in Glenn's career include his extensive experience developing and implementing effective, long-lasting CDI programs in both the inpatient and outpatient setting.
That's
So
right.
bravo and kudos to you, Glenn.
Thank you.
I can't believe that you're on as my guest today. Welcome.
Glad to be here. Yeah.
Love it. Love it, Glenn. Now, you know what? With this incredible bio that I just read to my audience, your years in this industry are completely commendable, right?
Yep.
Now, you and I have known each other for a couple of years here on LinkedIn.
Yep.
And of course, you even had me on your podcast back in the day on Wiser Wednesdays.
Right.
Now, I was just waiting for the right time, like I said, to bring you on with me. It's all about timing, right?
Right.
And with my underlying theme of leadership for my season 6's guests, of course, I had to bring you on in season 6.
Yeah.
So you're simply one of the best stewards, in my opinion, of CDI, and your vision for the heights that CDI specialists can reach is simply extraordinary. So it's clearly obvious to me that you're passionate about clinical documentation improvement. So I want my audience to be aware of that passion, right?
Okay, yeah.
So I'd love it if you could share with my audience what it is that inspired you to dive into this world of clinical documentation improvement and what the day-to-day looks like for a CDI specialist today in 2022.
Great question. So I really fell into the profession of CDI even before it was called CDI, because I was working with a company in Tennessee that paired up a coding or HIM professional with a specially trained physician in documentation, going back to 1995. And then I saw what we were doing in helping physicians document more effectively. So I finally said to myself, when people ask you when you're young, maybe when you were young as well, what do you want to be when you grow up? And you say a fireman, some people say fireman, a doctor, a lawyer. Well, it took me about 34 years to figure out what I wanted to do when I grew up. And so that's how I got into the world of, or entered my a long career in CDI, was kind of falling into it. And I've taken with the opportunity to advance myself and really trying to help other CDI professionals or people interested in CDI understand the intrinsic value that we bring to the table. It's not just about CCs or MCCs or quality metrics or quality reporting metrics for U.S. healthcare and the bundling for sepsis and all core measures. It's about the physician telling the patient's story on behalf of the patient, fellow physicians, nurses, and case managers and discharge planners. That's what kind of enlightened me about CDI. It's truly helping the patient. That's really that's really what drives me, is helping the patient, help the physician, help their patient, and help the patient get the best possible care. But even more importantly, or just as important, solid quality outcomes where the hospital and the doctor get paid for the work performed. Because after all, it is a service, and hospitals and physicians need to get paid.
Absolutely. Absolutely right. It all centers around the patient, right? The work that you and I both do. Absolutely. Right. It is the patient that is central to everything.
And I want to add, as I'm a firm believer, as we develop these software, artificial intelligence, I'm a supporter of them, CAPD, prioritization of records for supposed improvement, i.e. focusing on those cases with the largest opportunity for likelihood of reimbursement improvement. But I believe we forgot to pay. There's a patient in the chart, that we're working with physicians to help their patients. That crucial piece of, it's all about the patient has got lost. It's become lost in the field of CDI.
Well, yeah, I mean, over the years, we've seen, my father is now a retired internal medicine physician. And
wonderful.
When he started, when he came to the country and had to repeat his residency again, right? It was a different time growing up here in America in the 1980s. It was just different for physicians. It really was
about the patient.
That's right.
These rules and regulations from payers were much less, right? So they really found time, and this was well before the EHR took hold, right? So
yeah,
he was busy scrawling that
that's
terrible
right.
handwriting
You know
in the
what?
charts.
You know what? You know, before the EHR, we had difficult. One of the benefits of EHR is we can actually read the
We can
document.
read the, exactly.
Sometimes it makes no sense the way they cut and paste in the copy and paste and so forth. But at least we can read it.
But at least
When
we
we
can read
had,
it.
when there was paper charts or dictation, there in my mind, there's no arguing. We had better documentation.
Yeah, we definitely did. Absolutely right.
There wasn't anything of copy and paste.
No.
I can say I worked at a hospital in Towanda, Pennsylvania. There were paper records. I worked with physicians to improve their documentation truly on behalf of their patients and the consultants and the coders and the hospital and all that. Soon as we went to an EHR, the documentation quality went down the tubes. It was detrimental to the quality. I had to kind of teach them all over again to remind them about the standards of documentation for their patients.
Absolutely. Now, so you're touching on a really good point in terms of a deficiency that you see in clinical documentation today, right? So I agree with you. It's definitely the EHR that is problematic. But for my second question, I would really like to know your thoughts on what it is that are in your top 5 things that you see that are deficient today in the clinical documentation that you read every day. You know,
Okay,
what are those things that are missing? Your top 5.
Too bad we don't have an hour because I can really enlighten you.
I'm going to bring you back. Don't you worry.
Okay,
don't you worry.
Okay, so the top 5 deficiencies I see is number 1, first and foremost, the lack of a patient story, describing, telling, reflecting what's happening with the patient in the ED and the H&P. And why is that detrimental? Because it makes it hard for the case manager or the payers to see why this clinical decision was made to hospitalize the patient. And it's the starting point of a catapult. It's almost like a in the winter avalanche. You know, the avalanches start out small, then they get bigger and bigger as the forces of the snow going down the trail or mountainside. It's just like, it's similar to that. We have poor documentation, insufficient, also known as poor. And what happens is, then we have questions of whether the patient needs to be in the hospital. Then we have case managers with nothing to work with. Then they get a denial or level of care downgrade. Then the physician advisor or the physician has to do peer-to-peer. So you see how it's almost like a domino effect. So that's number 1. Number 2, we have excessive copy and paste. Okay, we have consultants stealing, involved in the theft. They actually steal the documentation from the attending on their history of present illness. That's a no-no, and it detracts from the attending understanding what the doctor's thinking. So excessive copy and paste, particularly in the progress notes, that leads to inconsistent documentation, contemporaneous. The need for contemporaneous documentation, clinical context, timing, and so forth is detracted from. It leads to unnecessary denials, clinical validation denials. The third is dropping off diagnoses. For instance, the CDI will query for sepsis or query for acute respiratory failure. The doctor writes it once. That's not sufficient. Every note has to stand on its own. Every progress note must stand on its own, as you cannot rely on the previous note or the note after. And so if you have a diagnosis of this acute hypoxemic respiratory failure as your major CC, and we look and it doesn't appear anywhere in the chart, there we go. We got another denial from the payer because they only see it once. The fourth insufficiency or detraction in the quality of documentation is conflicting documentation. Okay, if Dr. Jake Martin, who I've worked with since 1995, just got off the phone with him on a couple of denied cases, because I learned from him. He appeals cases in real time, and so I learned from him. One of the things that that we brought up for today was the fact that if a consultant that says this is a type 2 MI, and the doctor doesn't acknowledge it and actually put it in his progress note, he might say thank you for the consult, but does not put that diagnosis in his progress notes and discharge summary. The payers are now saying that's a disconnect. The doctor he ordered a consult and didn't acknowledge the consult and put that diagnosis. They're not allowing the diagnosis. Okay, so think about it. We see a diagnosis of acute hypoxic respiratory failure. We say we don't have to query. The code is going to pick it up. Well, the payer is going to deny that from the clinical validation. So that's number 4. And I think the 5th is the quality of discharge summaries. CDI, for the most part, is not working on discharge summaries. We don't look at discharge summaries. We'll look at the H&P and progress notes historically. And think about the patient. A large number of patients, it varies. Some journal articles have said, we've done a study and we see 30% readmission rate because of poor discharge summaries. But the fact of the matter is, a large number of these bounce backs or readmits because the discharge summary is not complete. The Joint Commission has 6 requirements for discharge summary. The National Quality Forum has some requirements as well. The Society for Hospital Medicine, which is the group for the hospitalists, the hospital medicine, has come up with a 20-point checklist of what needs to be in a discharge summary. You don't necessarily have to hit on every one of them, but those that are relevant to that particular stay. And that's another area of documentation deficiency that leads to poor handoffs, ineffective handoffs, bounce backs, unnecessary readmissions. Then you get into a case of the hospital won't get paid for that particular readmission because they say it's related to the first one. And I see that quite frequently now. Anything that, even if it's not related or closely related, they're going to take the opportunity to pay or not to pay. So let's really avoid or cut down on unnecessary self-inflicted readmissions with better discharge summaries. I don't mean discharge summaries I've seen of 10 pages. I just saw residents the other day in Mississippi, 10 pages of a discharge summary. What primary care physician do you know who's going to read 10 pages of a discharge summary? Do they have time? No,
they don't.
A discharge summary should be maybe a page, 2 pages long, maybe 3 pages long on an extended stay. Oh, and I lied. I got one more. Can I give you one more?
Please
Okay.
do it.
The other one is, Medicare requires extended stays over 20 days, a statement or rationale. Doesn't have to be a formal statement of why the patient needs to be in the house. Why is that? Because usually at 20 days, patients are going to be outliers from a payment perspective. Okay, and OIG just did a report on outlier payments. And I'm seeing more denials from payers, commercial payers and Medicare, commercial Medicare, straight Medicare. Why? Because if they can find a reason why the patient doesn't need to be in the house for that, let's say 18 days, 20 days, Medicare is 20 days. All they have to do is say, okay, we see delays in care, or we see delays in discharge planning, or we don't see a reason why the patient needs to be hospitalized. Guess what happens to your outlier payment? Bye-bye. And outlier payments don't make you whole, but they reduce the loss that you take, that you face with extended stays. So why would you want to take food from the baby's mouth?
Yeah. Wow, Glenn. I mean, your acumen in this space is profound. Well, I know I have to bring you back for a part 2 session where you can really dig in deeper, right?
Well, CDI should be a passion of everyone's. It's not a job. And
yes.
would you say that in your, and you're on listservs and you see some of the type of the posts and so forth. I'm sensing, I don't know about you, but I have a strong, and working with CDI people personally, there's some good people in the profession, but a lot of them are, I think the biggest downfall of CDI not achieving high performance as we should, as we can, is because people see it as a job. It's not a job. It's not a way. It's a calling. It's a passion. And unfortunately, if you don't have that drive that I and you have and others have, you're not doing justice to the profession at all.
I completely agree with you, right? Because in so many of these organizations, the way the personnel are instructed to do their work is simply performance-based, right? It's not the employee's fault. It's not the CDI specialist's fault. It's the way it's set up.
Absolutely. It's task-based. Think about it.
Right.
How do you get judged for your performance in your annual reviews or your 6-month reviews?
It's
number of queries left, number of charts reviewed, number of CCs, MCCs captured. What is the query response rate? What is the query agreement rate? What's the case mix index increase? Those have nothing, totally anything remote to do with documentation integrity.
Exactly right, Glenn. Amazing. Like I said, I'm going to have to bring you on for multiple episodes because we can dive into each one of these hot topics individually, right? And really spend time trying to find out how we all can do so much better.
Right. Hey, by the way, we have a Finally Friday tomorrow. It's going to be a great Finally Friday.
Can you share with my audience what is your Finally Friday?
Oh, Finally Friday. Oh, I'm sorry. Finally Friday is something that Ernie, who's a founder of Topcom, I'm a co-founder. We have a set group of panelists who call in on Fridays, and we have a different topic, and we invite different guests to come on. Tomorrow's is going to be this is going to be real juicy. Okay, it's going to be a doozer. We're going to talking to Val Krauss, who was the case management VP for a big health system, a nationwide health system. We're going to be talking about and discussing how to form, what are the components of, and what are the benefits are, and how to develop a multidisciplinary approach to CDI with physician advisors, case management, discharge planning, social work, physical therapy, and the physicians, of course, how to develop a multidisciplinary approach, and denials and appeals as well to CDI, because CDI there's no way CDI can possibly improve the integrity of the documentation. It's too lofty. It's too lofty an effort. We need help from everyone going down the same path. So it's really, I think it's going to be enlightening, and I encourage everyone to call in. By the way, there's no cost to attend.
Absolutely. I am going to put all of those details in my show notes because I am a member of your Top Gun and the Finally Fridays. I've attended so many of these sessions. It's fabulous. So I think if I put it out there for my audience, you can have many, many more people participating and supporting the effort. Yeah. Absolutely.
We're not trying to sell you anything. Please.
Yeah. No. This is all education based, just like my podcast. It's the same thing. It's the more we all know, the more we can all help contribute to the betterment of this particular space, right? That's why I had to bring you on.
Oh, thank you.
Yeah, absolutely. Now, you know what? Those ICD-10-CM fiscal year 2023 guidelines just came out. Now, you're a pro in this world of diagnosis coding. So what can you share are your best guideline additions that they've made for 2023? And of course, the publication is going to start in October 1st, 2022.
I saw some of the codes. I looked at the coding guidelines. Okay.
Yeah.
And really, it goes back to is a patient story there?
Good.
Contemporaneous. Really, a doctor. And I'm going to say this because I think it really brings home the point. okay, CDI, and when we get new codes, okay?
Yeah, yeah.
Medicine hasn't changed. What's changed? The specificity in diagnoses, right?
Yeah.
It's the same thing with ICD-9 and 10.
Mhm.
People thought it was the end of the world. No, medicine hasn't changed. It's just how we document the diagnoses. The medicine, there's always continual advances, new drugs, new studies about outcomes and what drugs to use and so forth, and interaction of best practices of working up a patient, okay? But medicine hasn't per se changed. And if you look at the updated coding guidelines, there may be 3 or 4 guidelines that actually made any sense or really have major implications. And so the really best way to approach the guidelines is to recognize that it's the documentation is about the patient story. It's not necessarily about coding. Coding takes care of itself if we have appropriate documentation. And it goes back to what Dr. Martin and I have presented numerous times. His title is, "It ain't so just because a doctor said it's so." And before, it used to be, way back in the 80s, if a doctor said it, it was accepted by the payer and we code it, right? Now today, if it said, it ain't so just because a doctor said it so. The codes, a doctor can say sepsis 5 days in a row and put in a discharge summary, and we may not get paid for it. Why? Because it's not the patient story doesn't depict that diagnosis. Let me give you an example. Dr. Martin and I were looking at a case about 2 weeks ago of a commercial payer denial that cost the hospital $10,750. That's no chump change, is it? $10,750.
Wow.
Okay, there was no way to what Dr. Martin calls rehabilitation, when we were not able to rehabilitate the charge. You know why? Because the doctor said in his H&P on the constitutional physical exam, patient alert and oriented ×3, just finished polishing off a cheeseburger and fries, resting comfortably on the bed, watching TV. Okay, and that's no lie. That's exactly what he said. What do you think the diagnosis was? Severe sepsis, #1.
He's
Number
eating a
2,
cheeseburger. How?
Yeah.
How is he septic? He's eating.
Number two, acute metabolic encephalopathy secondary to #1. Now, what do you think the payer said when they got that shot? I read the denial letter. I didn't read it. Dr. Martin read it to me. It said, not clinically supported, and validated, and they even could copy and pasted the doctor's constitutional physical exam, that piece about the cheeseburger, they put it right there in the sentence of the denial.
Wow.
How do you appeal that? Can you?
You cannot. You should bury your head in some level of
sad?
shame.
You know what's sad?
What?
CDI reviewed that case. They saw the word sepsis, and what do you think they did? They moved on to the next case.
They moved on. They happily slapped
So
it on.
the moral of the story is, if you're in CDI and you see a diagnosis, please don't only think you have to clinically validate it with indicators, white count, fever, tachycardia. What does the patient look like as read by you or an outside review? What does the patient look like? How did it manifest? What's wrong with the patient? Can someone see the diagnosis of sepsis in the chart? Because if they can't, you can rest assured the payer is not going to accept the diagnosis. I had one, and I'll be quick on this one. Okay, the doctor said acute respiratory failure. Okay, you asked me for one more thing about documentation deficiency, and I really got to say this one. Okay, the problem with queries is when you query a physician for, let's say, acute respiratory failure on day three on the patient, or let's say day 2, because we don't necessarily look at cases the first day they're admitted, because some people tell me it's too early to tell. Okay, or if we do, we don't usually issue a query. Okay, so we wait to the second day and we ask for acute respiratory failure. Well, the doctor is going to say, oh, of course it was. But on the day we queried the physician, there's no acute respiratory failure because the patient got breathing treatment, steroids, chest percussions and all that. I know on oxygen, let's say 100%, then we tailor, we lower we titrate it down to their baseline 2 liters. Well, that doesn't look like acute respiratory failure. So we really need to be proactive and get physicians to understand that, call it what it is. If it's a donkey, call it a donkey. If it's a horse, call it a horse. If it's a zebra, call it a zebra. If it's a zebra, don't call it a monkey with acute respiratory insufficiency. Call it, describe, tell, depict, and reflect what you see, and call it what it is in your diagnosis and why. That's what CDI is about, okay?
I love it, Glenn. I couldn't agree with you more. Our physicians, our providers need to do a much better job, get back in time, right, to when things were on paper, when they were really documenting, painting the medical picture
that's right.
of the patient so
that what
much
your title
better.
was, painting the picture?
It really is. Yeah.
So it's painting a picture of the patient's severity. That's something we need to get involved in. We must, not need to, we must.
Absolutely. I couldn't agree with you more, Glenn. Now, I know we are running out of time here
I'm
today.
sorry,
And like I said, no, I'm going to bring you back again and again. But, is there anything else in terms of your closing thoughts, something we might have missed on today's
absolutely
conversation
and
that you can just close?
I'll make it a closing
conversation with.
In without writing a book, okay? Because I'm so passionate about what I do. But here it is. We see, I just got something from an association of CDI about CAPD, the standards and compliance, okay? There's no question that, I'm going to close with this. There's no question that artificial intelligence, NLP, whatever you want to call it, is taking on new meaning and and getting a grip on physician documentation. So my closing thought is, with that coming into bear, it's imperative that we reinvent what we're doing. If we do not, we may not have a position, or our relevance in the world will be totally markedly decreased. So that's why I advocate for CDI getting away from queries as a hallmark and mainstay of CDI, and actually working with physicians as mentors and guides in helping them achieve the proper documentation. Because there's a misnomer. Clinical documentation improvement is not impacted, is not achieved by CDI. It's achieved by the doctor. She is the only one who can achieve documentation integrity with our help. Well, we have to take the initiative to start to acquire that skill set, knowledge, core competencies in documentation. What is a good history and physical? What are the standards of progress notes? I have lots of information on Top Gun about that. And then reinvent what we're doing, because if we don't, I'm hate to say this, but it'll be a slow death.
I love your closing thoughts. Incredible. It is up to our physicians, right?
Yeah.
To maintain the clinical
Absolutely.
documentation integrity. The onus is on them. Absolutely. Yeah. Couldn't agree with you more.
All right. Well, thank you for having me on the show. It's been great. I hope people take this information and run with it. And if they have any questions, they certainly can get a hold of me through LinkedIn. Be glad to point them in the right direction. Okay.
Wonderful, Glenn. Absolutely. I'm going to make sure, since you've just approved, I'm going to make sure that I put your details on LinkedIn as well in my show notes, as well as Top Gun and Finally Fridays.
Oh, thank you.
Absolutely.
Thank you, everyone, for listening to us. Keep up the good fight.
Thanks so much, Glenn. And
Thanks.
I'll see you next time.
Yep. Bye-bye.
And now it's time for my best practice tips in Trusty Tip. So in today's new compliance tip, I wanted to focus on the Rural Health Clinic, the RHC, and the Federally Qualified Health Center, the FQHC settings. So I'm going to be disclosing what's new for mental health visits via telecommunications in these places of service. Now, let's remember that CMS finalized regulatory language for mental health visits in RHCs and FQHCs in the calendar year 2022 Physician Fee Schedule Final Rule. And effective January 1st, 2022, we may be able to provide mental health visits using interactive real-time telecommunications technologies. So RHCs and FQHCs can now provide telecommunications for mental health visits using audio-video technology as well as audio-only technologies. Now, we can use audio-only technologies in situations when our patients cannot access or they don't consent to using audio-video technologies. Now, we can report and get paid in the same way as in-person visits, which means, let me be clear, audio-video visits have to require the use of modifier 95, which is for synchronous telemedicine services rendered via real-time interactive audio and video telecommunications. And let's remember that our audio-only visits, we have to be appending the new service level modifier of FQ. That's F as in Frank, Q as in Queen. Now, these particular visits are going to be different from telehealth services provided during the COVID-19 public health emergency, the PHE. So let's be mindful and don't bill HCPCS code G2025 for a mental health visit that you provide via telecommunications. And we are aware to read clearly the MLN Matters article SE20016 for more information on the compliant billing of HCPCS code G2025 for professional telehealth distant site services other than mental health visits during the COVID-19 PHE. Now, let's get into an example of proper RHC claims for mental health visits via telecommunications. So we should be using that revenue code 0900 on our claims, as well as our HCPCS code 90834. That's actually our CPT code, right? 90834, or another qualifying mental health visit payment code. And with that code, we should be appending the modifiers 95, as I stated before, that signifies audio, video technology, or the new modifier FQ, F as in Frank, Q as in Queen, for our audio-only telecommunication services. And then, of course, the modifier CG, which is required. That's a must. And now here's an example of a compliant FQHC claim for mental health visits via telecommunications. Again, let's be mindful that revenue code has to be 0900. And then we have an option of two different HCPCS codes. One is a HCPCS code, one is a CPT code. The first HCPCS code is G0470, or another appropriate FQHC specific mental health visit payment code. And then again, for that HCPCS code, you have to append the modifiers 95, again, which reflect the audio video service, or the new modifier F as in Frank, Q as in Queen, for the audio only type of service. And then for the second option, there's that same revenue code 0900, or that CPT code 90834, or another FQHC PPS qualifying mental health visit payment code. And in this instance, the modifiers do not apply. Now, let's remember that our in-person mental health visit requirements. These in-person visit requirements apply only to a patient getting mental health visits via telecommunications at home, when they're at home. Now, there must be an in-person mental health visit 6 months before the telecommunications visit. And in general, there must be an in-person mental health visit at least every 12 months while the patient is getting services from you, their provider, via telecommunications to diagnose, to evaluate, or to treat mental health disorders in their care. Now, what's new right here, there's brand new language right here that says, quote, you should note, in Section 304 of the Consolidated Appropriations Act of 2022, they delayed the in-person visit requirements under Medicare for mental health visits that RHCs and FQHCs provide via telecommunications technology. For RHCs and FQHCs, in-person visits won't be required until the 152nd day after the end of the COVID-19 PHE, end quote. So what that means, this brand new language, is that in the RHC setting and in the FQHC setting, in-person visits won't be required until after 152 days after the end of the PHE. Now, there are still some exceptions here. So they're going to be allowing for limited exceptions to the requirement for an in-person visit every 12 months based on the patient's individual circumstances, right? In which the risks and the burdens of an in-person visit may outweigh the benefit of coming in. Now, these include, but are not limited to, when these 4 things happen. So number 1, an in-person visit is likely to cause a disruption in service delivery or has the potential to worsen the patient's condition. Or number 2, that the patient getting the services is in partial or in full remission and only needs maintenance level of care. And then third, that the clinician's professional judgment says that the patient is clinically stable and that an in-person visit has the risk of worsening the patient's condition, creating undue hardship on the patient or the patient's family. And then finally, if that patient is at risk of withdrawing from care completely, that has been effective, in fact, in managing the illness. So with proper documentation, the in-person visit requirement isn't applicable for that 12-month period. And remember, you must be mindful you have to be documenting the circumstances in the patient's medical record. So then providers need to take action right away, right? Absolutely. You need to be making sure that your billing staff knows about these changes that I highlighted above, that there have been regulatory changes for mental health visits in RHCs and FQHCs. So billing information for mental health visits need to be done via telecommunications, right? We have to be mindful of those changes. And just because there's a delay in certain in-person visit requirements for mental health visits, it doesn't mean that you should be waiting till that 151st day, for example, to begin to develop a strategic plan for the team. So don't wait until the last minute possible. You should be starting to develop your strategic plan from right now. So it's fundamental, if you have Medicare as a payer, to keep your eye on correct and compliant coding and billing practices and making sure that you adhere to them, to all of them, to ensure that you are meeting the medical necessity from the very start. Because when the documentation paints the medical picture with clarity and vibrancy from the onset of care, a certified medical coder can then abstract codes with accuracy. And finally, I focus Season 6's Spark on vision and leadership. I want this 6th season Spark to be filled with the world's thought leaders, writers, artists, philosophers, everyone who inspires the need for vision and leadership in all that we strive to do. So, in this week's inspiring quote in Spark is from Japanese philosopher Daisaku Ikeda. A healthy vision of the future is not possible without an accurate knowledge of the past. Absolutely true, right? I think this quote inspires us. It reminds us that our past experience, our past knowledge is fundamental for our brighter futures. It is with this mindset of remembering our key takeaways from our own past that we can bring them into our visions for our futures. I am happy Daisaku Ikeda's spark still shines on in all of us today. So that wraps up today's episode. And as always, I appreciate you all diving into today with me. If you want more information from me, please go ahead and follow me on LinkedIn. I'll leave links to everything in the show notes below. Now, all right, you guys, it's the first day of summer, right? It's officially here, and it is time to start making all those summertime plans. Go start having some well-deserved fun. Now, please have an amazing week ahead, and remember to carve out time for yourselves each and every day to keep your mental health strong. Stay sane, and please continue staying safe and healthy, right? COVID-19 is still among us. It's still here. Now, thank you so much for listening in on today's very special episode, and I hope every week with me brings you closer to helping your providers paint a masterpiece. See you next Wednesday.